आपने बताया नहीं क्या हुआ? हाँ
Good evening, all. Welcome to ISA online PG class. I am Professor Naveen Malhotra, ISA National Secretary. Greetings from ISA National Headquarters. Today we have amongst us Dr. Sunil P.R., who shall be speaking on perioperative management of a patient with diastolic dysfunction. I have muted you all, and at the end of the session, you will be given permission to unmute yourself. You are requested to type your questions, queries in the chat box, and so that they can be taken care at the end of the session. I have with me Dr. Nishant Sahay from AIMS Patna, and who is the coordinator for these online PG classes. I request Dr. Nishant Sahay to please carry over the proceedings, introduce the speaker, and coordinate the session.
Thank you, sir. Today we have a very eminent speaker, Dr. Puthuvaseri Raman Sunil. So he is a professor in the Department of Anesthesiology at the Sri Chitra Tirunal Institute of Medical Science and Technology in Thiruvananthapuram in Kerala. Dr. Sunil sir's interest is he works in the area of adult and pediatric cardiac anesthesia and interest in transesophageal echocardiogram. He is a treasurer of the ISA Kerala branch and coordinator of the Dr. KPR Award Committee. He is a former secretary of the ISA Thiruvananthapuram branch. And a warm welcome, sir. And we can start, sir.
I must add on here that Dr. Sunil is a very nice human being. He's a good clinician, a staunch ISA worker, and an office bearer, and a very nice human being. Over to you, Dr. Sunil.
Thank you, sir. Thank you. So my topic for today is perioperative diastolic dysfunction. So now let me present you with the case scenario. We have with us a 70-year-old woman who has undergone mastectomy under general anesthesia. Preoperatively, she was noted to be hypertensive. She was being treated for this with amlodipine on 10 milligram once daily. Her pre-op BP was recorded at 170 over 100. An echocardiogram was done in view of her age, in which it showed good ejection fraction, 60%, no regional wall movement abnormality. The echo showed features of left ventricular hypertrophy. The overall comment was good LV. The good LV usually suggests that all is well with the heart. And intraoperatively, what was remarkable was there were periods of hypotension that responded well to crystalloid infusion. Now this lady was extubated in the operating room itself, and later in the post-op recovery, 4 hours later, she was noted to have labored breathing. She was disoriented, and her saturation was noted to be 85% on oxygen mark. Her heart rate at this point was 110 beats per minute. Blood pressure was noted to be 210 over 110 millimeters of mercury. Auscultation revealed basal crepitation. So as is usual at this time, a TROP-T was sent, which was shown to be negative. An emergency 12 lead ECG was remarkable only for tachycardia. So an emergency bedside echo was ordered, which showed a poor window. This is a common enough finding at the bedside in the ICU. But the window was good enough for the echocardiographer to make 3 points. So point number 1, the LV was good. There was no pericardial effusion or no evidence of pulmonary thromboembolism. And at this point in time, the patient developed AF, and the blood pressure drops to 100 over 80 millimeters of mercury. And the ICU is alerted that a ventilator should now be kept ready. So at this point, we have evaluated the patient appropriately, but we don't have a diagnosis yet. she is not suffering from myocardial ischemia, or nor she is in systolic heart failure, because echo shows good LV. Good LV usually for us, for most of us, would show cardiac failure. So further progress, we need a diagnosis. Now, these are the two things I have heard described in the ICU often. Is it non-cardiac pulmonary edema? Or did the anesthetist transfuse too much fluid in this elderly patient? So if you practice long enough, you will encounter a case like this, and you most probably with advanced knowledge, you will not hear the diagnosis anymore. Why did the initial consideration arise that this was not a cardiac cause for this lady's deterioration? We saw the pre-op echo and we saw the post-op echocardiogram, and we saw that the patient had good ejection fraction. And this usually suggests to the clinicians that all is well with the cardiac function. And on the face of it, the patient seems to have no cardiac reason for her current deterioration. This used to be the case in the past because there was poor understanding of diastolic function. Because systolic function is intuitively meaningful, the heart needs to contract to provide a good cardiac output. But diastole needs to be understood. Diastolic dysfunction is not uncommon. It accounts for nearly 50% of all cardiac failures. The prognosis and mortality is the same as systolic. Diastolic dysfunction is not kind, it is not benign, and mortality is 4 times when compared with the normal population. And diastolic cardiac failure is possible with normal ejection fraction, normal systolic function. This is why it was called heart failure with preserved ejection fraction. Now, what differentiates a systolic failure from a heart failure with preserved ejection fraction? Heart failure due to diastolic dysfunction. If you take mitral regurgitation or peripheral edema, LV dilatation, all these things will be present only with systolic heart failure, whereas these things are rare with diastolic heart failure. Other than these three, mitral regurgitation, peripheral edema, and LV dilatation, other features as far as cardiac failure is concerned are the same, whether it is systolic heart failure or diastolic heart failure. Now, let me come to diastole per se. How long is the diastole? Diastole lasts between aortic valve closure to mitral valve closure. So, aortic valve closes at the end of systole. So, at this point, when the aortic valve is closed, the diastole starts. And when the mitral valve closes after LV has filled, the diastole has ended. Now, this is often represented in classrooms using this pressure volume diagram. So, this is a very important diagram as far as postgraduates are concerned. This is a pressure volume loop showing a single cardiac cycle. Now, to derive this pressure volume loop requires a high fidelity catheter and can be derived only in the cath lab. But it helps us understand the different phases of cardiac cycle. So you have pressure here on the Y and volume on the X axis. So this is the point. This is the point at which the mitral valve closes, contraction, aortic valve opens, aortic valve closes. So this is the point at which diastole begins. So this point diastole begins, and this is the point at which the mitral valve opens, and filling occurs, and this is end diastole. We'll come to the pressure volume loop a little bit later as well. Now, have we really answered the question when the diastole actually begins? I said earlier that diastole begins when the aortic valve closes. But at a molecular level, diastole begins when the actin-myosin cross bridges dissociate. And this occurs in late systole. At a physiological point, diastole begins when the intraventricular pressures fall. So when does diastole actually begin? Modern day understanding, we know that diastole begins in late systole when those actin-myosin cross bridges dissociate. So diastole is not a transient simple phase between two systoles, like the heart has a small rest between its main work, systole or contraction. Diastole has its own place, it is important, and it is energy consuming. Now, systole and diastole, they are a continuum. There are no, these are not separate phases. Like diastole is not like a vegetable salad between two pieces of bread. So let's come to systole per se. Systole, LV systole has 4 kinds of movement. If you look at figure 1, during contraction, the LV wall move inward. And during contraction, the LV wall thicken. So these are the radial and circumferential contraction. Another kind of contraction is LV moves from the base to apex. Base is where the mitral valve is situated, moves from the base to apex. And the most important movement which we haven't studied so well in our undergraduate days is LV torsion. LV torsion is akin to wringing a towel. It's like the heart is being squeezed at both ends. Now, if you look at the 3D model of LV, and this is my dog looking up at me, what he'll find is that at the base where the mitral valve attaches, the LV rotates in a clockwise direction, whereas at the apex, it rotates at a counterclockwise rotation. So LV torsion occurs during systole. And after this torsion, what occurs is the untwisting. The LV untwisting occurs late in the systole itself. Now, it doesn't wait for the diastole. It starts late in the systole. The LV, which was twisted, now begins untwisting. And this releases stored elastic energy. And this stored elastic energy causes a suction. So LV is not passively filling. LV is not just filling because there is a pressure gradient. LV is actually sucking blood from the LA. So this suction effect is very important for the LV. So this is a change in script from what you have understood about diastole. LV actively works during diastole. Now, with diastolic dysfunction, you are going to hear 2 terms repeatedly: abnormality of relaxation or decreased compliance. And all this, in spite of all this, cardiac output is maintained at the price of increased filling pressure. So what is diastolic dysfunction? It is the inability of ventricles to fill at low pressure. The filling pressures are considered elevated when either the pulmonary capillary wedge pressures are more than 12 or an LV end diastolic pressure is more than 15 millimeters of mercury. Now, we need not measure these pressures, but this is where the definition stands. So, diastolic dysfunction and diastolic heart failure. Diastolic dysfunction is when you have features of abnormal diastolic relaxation. You can find these features using echocardiography. You can find features of diastolic dysfunction using echocardiography. Whereas diastolic heart failure is when you have features of diastolic dysfunction plus there is a clinical findings of heart failure. So diastolic dysfunction can occur by itself and it can be a substrate to develop diastolic heart failure. Now, little more detail about diastole. As you all know that there are 4 phases: isovolumic relaxation, rapid filling, diastasis, and atrial contraction. These are the 4 phases of diastole. Now, let me explain this with this echo loop. Now, this is a mid-esophageal view using a trans-esophageal echocardiogram. We have left atrium here. This is the mitral valve. These are the mitral valve. And this is the LV and aorta. Okay, just bear this in mind. And isovolumic relaxation is when the aortic valve is closed and the mitral valve is closed. Both aorta and mitral valve is closed, and LV untwisting occurs, and an active suction is being readied in the LV. So as soon as the mitral valve opens, there is a rapid inrush of blood from LA to LV, causing the phase called rapid filling phase of the diastole. Most of the filling will occur during this phase. Now, Once the inrush of blood from LA to LV has occurred, the LA pressure will drop and almost equalize to LV. There will be a phase of low filling called diastasis. Filling continues to occur, but at much lesser rate. Now, the concluding part of diastole is the atrium will contract. Will contract and push the remaining blood into the LV, from LA to LV. So these are the four phases of diastole: isovolemic relaxation, that is preparing the heart for diastole, rapid filling, diastasis, and atrial contraction. And then the mitral valve closes and the diastole is ended. And note again, there is a period where the mitral valve is closed and the aortic valve is closed and the contraction process begins. That is the isovolemic contraction. So that's not part of our presentation today. We'll stick to diastole. So I'm coming again to the pressure volume loop. So this is quite important for you when you're asked a question with regard to valvular diseases. You should be able to draw a normal pressure volume loop and the corresponding abnormal pressure volume loop of the valvular heart disease. So we'll stick to diastole today. So I explained earlier that it begins, at least at an anatomical level, diastole begins at aortic valve closure. From aortic valve closure to mitral valve closure is the time of diastole. Between aortic valve closure and mitral valve opening, between these 2 points is the isovolemic relaxation time. This is the isovolemic relaxation time, just written as relaxation. So this isovolemic relaxation occurs between the closed aortic valve and the closed mitral valve. And as soon as the mitral valve opens, the rapid filling phase occurs. There is a phase of diastasis where filling has somewhat less. And there is a concluding part, the atrial contraction. So when you draw this part of the pressure volume loop, the filling portion of the diastolic pressure volume loop, it has to be drawn with a slight upward slope because the atria contracts here and the left ventricular end diastolic pressure should rise. So note the shape of the curve. This portion should be drawn slightly slanting upward. Now, it's not possible to understand diastolic dysfunction without understanding echo. Echo is everywhere in anesthesia nowadays, be it vascular access, regional nerve block, lung ultrasound. So there is no need for anesthesiologists to shy away from ultrasound of the heart. You should all be familiar with echocardiogram and 2D images. I'll be using 2D images and I'll explain them to you. I'll be making them very simple. And Doppler, we will be using pulse wave and tissue Doppler. Just understand that Doppler is a means to measure blood velocity. Doppler is to be always written with a capital D because it is named after a person, Christian Doppler. And just bear in mind that all images are from transesophageal echocardiogram. The images as well as the polarity of pulse wave Doppler, all those are reversed with transthoracic echocardiogram. So please bear in mind, I'm using only transesophageal echo. And these are the echocardiograph tools: mitral inflow Doppler, tissue Doppler, tricuspid regurgitant velocity, and the LSI. So I'll stick to these four. And there's no need to be intimidated by the use of these terms. I'll explain them to you in coming slides. So, but there are plenty of echocardiographic tools for studying diastology, but I'll just stick to these four. And using the echo tools, we divide diastolic dysfunction into 3 grades. Grade 1, impaired relaxation. Grade 2, pseudonormal filling. Grade 3 is restrictive filling, which can be reversible or irreversible. And echo should also be able to tell us is the filling pressure elevated or not. Okay. Now coming to a transesophageal echocardiogram, this is the 5-chamber view. 5-chamber because usually you see 5 chambers. This is the LA, mitral valve here, left ventricle, aorta, right ventricle. And RA is also seen, but not in this particular view. So let me make use of this view. And this wall which separates the right ventricle and left ventricle is the septum. And opposite to the septal wall is the lateral wall, or more correctly, the anterolateral wall. So let's take this 5-chamber view, and this dot is a hypothetical RBC. Now, the course of the RBC from the LA to LV is through the open mitral valve. It hits the lateral wall and it rounds off and goes into the aorta and systemic circulation. So that's the path it takes. So this is how blood flows from LA to LV, striking the lateral wall, curving across into the aorta. Now, if you want to study a pulse wave Doppler, this is the view because it will capture the exact line of blood flow. To capture the blood velocity, a pulse wave Doppler is aligned across the mitral valve and placed at the level of the open mitral valve leaflet. So this is in real time captured in our OR. So this is what a pulse wave Doppler looks like. This waveform represents blood flow velocity across the mitral valve. Now let me explain this using this cartoon. All Dopplers are to be understood using the electrocardiogram also. So echocardiogram requires electrocardiogram. Both cardiograms are required. So this is the ECG of, and this is the blood flow velocity during diastolic. I have removed all traces of systole. I'm just sticking to diastolic. So R wave represents the start of contraction, and after the T wave, you get the diastole. So the first wave is the E wave. E wave represents the rapid filling phase of the ventricle. Isovolumic relaxation time is not represented here. So there is an isovolumic relaxation which is not shown in this Doppler. We cannot accurately measure it using this. But you do get the rapid filling phase shown by the E wave. So what is important is the E wave, and following which there is no flow or little flow called the diastasis, and there is the atrial contraction. So what we measure here is the E wave velocity and A wave velocity. Normally, E is greater than A. Now, I am done with mitral inflow Doppler. Now let me explain tissue Doppler. Earlier, we used Doppler to measure blood flow velocity. We can use Doppler to measure the myocardial velocity, the walls of the myocardium, the velocity at which they move can be captured. The myocardial velocity is not as high as the blood flow velocity. So to capture this, now this is the 4-chamber view, slightly modified from the 5-chamber view. You get LA, LV, mitral valve. So I am going to focus on the anterolateral wall of the LV. This is the anterolateral wall of the LV. You can see that this anterolateral wall is moving down with systole, and with diastole it is moving up. The downward movement and the upward movement can be seen. But now we can measure the velocity if we apply a sample volume here, just below the annulus. You keep a sample volume here, you can measure the velocity. Now, let me show you how it's done in real life. So this is the lateral wall of LV. I have isolated that. The sector is narrowed there, and the pulse wave line is kept along the lateral wall. Now I'm taking the Doppler. So these are the velocities of the myocardial wall during systole as well as diastole. We are today interested only in diastole, so I'll stick to the diastolic portion of the tissue Doppler. Now, analogous to the rapid filling phase, where the blood flows from LA to LV down by TE appearances, from down, the movement of left ventricular wall is up. So when during the E wave, when there is rapid filling, there is E prime wave caused by the myocardial wall. That is analogous to the E wave of blood flow, mitral inflow. And there is the A prime wave, which occurs due to the just after the atrial contraction. So these are not mirror images of the transmitral flow. These are separate entities by themselves. So these are myocardial velocities, not blood velocities, myocardial velocities. These are low velocities, and they are captured by what is called the tissue Doppler. Now, normally the E prime is greater than the A prime. That is, the rapid filling phase is predominant than the atrial contraction. When there is diastolic dysfunction, this reverses. And again, tissue Doppler is very important because it helps us know the filling pressure. So this is called lateral E prime because it was measured along the anterolateral wall. So this is called the lateral E prime. You can measure it at another location also. So you have to say it's lateral E prime. If it is more than 10 centimeters per second, that's a very low velocity. It rules out diastolic dysfunction. And the mitral E by the myocardial E prime, that ratio, if it is less than 8, it shows normal filling pressure. If it is more than 15, it shows increased filling pressure. So using these two, we can get a handle on what is the filling pressure. If it is in between these two, then it is termed indeterminate. Other echocardiographic parameters, LA size and tricuspid regurgitant velocity are important. I'm not going into detail regarding that because I'll be explaining diastolic dysfunction based on what the two echocardiographic modalities I just showed you. So I told you earlier there are three stages of diastolic dysfunction: impaired relaxation, pseudo-normal, restrictive function, which can be reversible or irreversible. And normal is when there is an active suction by the left ventricle. It is not passive filling, not just a filling across a pressure gradient, there is an active suction. So the rapid filling phase is predominant. So the E wave will be more than the A wave. E prime will be more than 8 centimeters per second, and E prime will be greater than A prime. The rapid filling phase predominates. So the E and E prime is always bigger than the A or A prime wave. Now let's see the impaired relaxation or grade 1 diastolic dysfunction. What happens here is that the LV, either due to aging or other disease processes, that it has now developed the inability to relax. Inability to relax is a big disease which you should all guard against. So this is LV has developed an inability to relax, and because of that, that suction effect is lost. So the E wave is now not predominant. Most of the LV filling occurs during the atrial contraction. So the E wave is less than the A wave, and the E prime velocity is less than the A prime velocity. And in absolute value, it is less than 8 centimeters per second. So this is the impaired relaxation. Easy enough to understand. The rapid filling phase is not the predominant one. The atrial kick is the predominant one. So now coming to grade 2, pseudo-normal filling. Now, what has occurred during this stage is that the failure to relaxation has worsened, and it has now caused a physiologic adaptation. What is the physiologic adaptation? There is an increase in left atrial pressure. Because of an increase in left atrial pressure, as soon as the mitral valve opens, the rapid filling phase predominates. That is, the E wave again gains dominance over A wave. E wave is greater than A wave on blood flow Doppler, whereas on tissue Doppler cannot be fooled. The E prime is less than A prime. So what has happened here? That is me just showing the E prime and A prime there. What has happened here is that normal, as you see on the left panel, diastole, a rapid filling phase is just it's an active suction. Whereas what now occurs here is it's a push from the left atrium. So this is what pseudo-normal has achieved. It has changed from, even though it has the blood flow Doppler has the normal appearance, there is an important change has occurred. It is not the suction from left ventricle, it is the push from the left atrium. Now, this is the worst stage of diastolic dysfunction, restrictive physiology. Now, what has happened is the left ventricle is not just unable to relax, it has become stiff and poorly compliant as a continuation of the disease process. So what has happened is, as soon as the mitral valve opened, there is an inrush of blood from LA to LV, causing a predominant E wave. So this E wave is really big. And as soon as the blood comes from LA to LV, the pressures equalize between LA and LV, and very little filling can occur with the atrial contraction. So the E wave is very predominant over A wave. The E by A ratio is more than 2. Atrial kick is not able to accomplish its function of filling. So the tissue Doppler again shows the E prime is less than A prime. So this is not a normal appearance to have a E wave that is more than twice the A wave. Restrictive pattern is something you should note in an echocardiogram. It indicates poor prognosis. There is high mortality irrespective of the systolic status, and aggressive therapy with angiotensin converting enzyme inhibitors with or without diuretics may lower restrictive to pseudo-normal. Stage 3B treatment does not change the restrictive pattern, that is irreversible restriction. Now, this is the flow chart to diagnose diastolic dysfunction. I am not going into details of this. This is very much simplified American Society of Echocardiographic guidelines. I don't know whether they will sue me because I have taken a lot of liberties in creating this chart. So next time you read an echo report, just don't focus on systolic function alone. Don't be reassured if you see a normal ejection fraction and no regional wall movement abnormality. You need to check the valve function also, and diastolic function. You should note what is the grade of diastolic function they have mentioned. And with the knowledge you have gained today, look at the E by A ratio, the absolute E velocity, and the lateral E prime velocity. And other markers of LV diastolic dysfunction on echo is one is left ventricular hypertrophy, LA volume enlargement and elevated, pulmonary artery systolic pressure. So, in addition, if suppose the echo does not mention diastology in specific or no echo has been done, please consider the following as risk factors for diastolic dysfunction. Age more than 70 years, female, the postmenopausal hypertensive lady with wide pulse pressure. This is being called the diastolic phenotype. Uncontrolled hypertension, previous myocardial ischemia, diabetes mellitus, comorbidities such as obesity and renal failure, and more importantly, a prior history of cardiac failure. And that is not documented, please consider that diastolic dysfunction is also possible. What are the risks of diastolic dysfunction? It can cause delayed weaning from mechanical ventilation, more use of vasoactive agents during and after surgery. In cardiac surgeries, there can be difficulty in weaning from cardiopulmonary bypass, and prolonged ICU stay and mortality are noted with advanced stages of diastolic dysfunction. So how do we conduct the anesthetic? Of course, preoperative evaluation, functional status and exercise tolerance. These are very important assessment parameters irrespective of surgery. Especially in the elderly, you have to know whether the patient is physically independent and what is the level of his exercise tolerance. And the elderly are likely to be on multiple drugs. Those drugs have to be optimized. They are likely to be on beta blockers, in which case they need to be continued. Angiotensin converting enzyme inhibitors or angiotensin receptor blockers, they are usually stopped on the day of surgery. We can have a discussion on this if required. Statin should be continued. Antiplatelet agents, depending upon whether they've had a recent stent or other indications. And diuretics, the patient is on diuretics, please continue them on the day of surgery also. If not, they would not have adequate urine output during surgery. Now, patients with diastolic dysfunction are very labile hemodynamically. And the reason for this is they have a high resting sympathetic tone and an altered baroreceptor sensitivity. So when this sympathetic tone is disturbed or abolished by the induction of general anesthesia or neuroaxial anesthesia, there can be fall in blood pressure sometimes precipitously. And they are greatly sensitive to alteration in volume status. If they are fasted overnight or they are taken up as late in the day, the elderly have altered thirst sensation, and any vasodilation induced by induction of anesthesia will be poorly tolerated. Besides, they could also be on diuretics. And third is that there is an exaggerated response to anesthetics. Both intravenous and volatile anesthetics, they are known vasodilators. They can interfere with inotropy, contractility of the heart, and produce arterial as well as venous dilatation. Now, what are the monitoring tools? Standard monitoring tools are, of course, required electrocardiogram, but blood pressure, saturation, end-tidal carbon dioxide, and so on. I'm not elaborating this. And with regard to invasive arterial pressure, if for major surgeries, invasive arterial pressures are mandatory because their blood pressure, as I explained to you in the previous slide, this is labile. So you have to fine tune their arterial pressure during induction. So it helps to have a arterial pressure. The assessment of volume status is also important in this patient, but central venous pressures do not provide an adequate observation of adequate representation of the volume status. But for major surgeries, I would prefer to insert a central venous line, mainly in the anticipation of the need for vasoactive agents. But pulmonary artery catheter and transesophageal echocardiogram, the pulmonary artery catheter provides very little information when it is considered with the risk, and transesophageal echocardiography is usually limited to cardiac surgery settings. So not much to say there. But regarding general anesthesia, there is a preference in literature for intravenous induction and maintenance with volatile agents and opioids, because this provides greater hemodynamic stability, and it is perceived, believed on the basis of few studies that volatile agents improve inotropic, leucotropy, or diastolic function. Regarding general anesthesia, good induction practices. The elderly, they require a reduced dose for induction. So the induction dose of most agents should be reduced by 30 to 50% in the elderly. And induction may be prolonged because of the slow circulation time. So titrate to effect, give an effect, wait for the action of the drug to take hold, and do not administer large boluses of drug, especially a drug like propofol. If you are using midazolam, please be aware that it takes a longer time to show its effect, and a smooth takeover from spontaneous ventilation to back mask is required. We must be careful to avoid hypoxia and hypocarbia. Both are known to worsen pulmonary hypertension, which can be present in these patients. And how do we maintain blood pressure in these patients? The systolic blood pressure should be maintained within 20% of baseline. Maintain the diastolic blood pressure, whatever it was at the beginning of before induction. Maintain the diastolic blood pressure, and keep the diastolic pressure greater than the pulse pressure. And factors that optimize supply demand, those should be addressed during the surgery. So this is a separate class. I am not going into details here. Now, regarding control of BP, the rule of 70s is important. If the patient's age is more than 70, keep the pulse rate around 70. So if the patient already presents with a high heart rate, dexmedetomidine would be a good choice. But if the patient was on preoperative beta blocker, I would advise caution in starting dexmedetomidine. Keep the diastolic blood pressure above 70 and the pulse pressure below 70. And this is taken from Sanders anesthesiology. I have added one more 70. If you can do all this, practice all this, you can practice beyond 70. So that's the rule of 70. So drug combination for hemodynamics. So these patients, when you manage them intraoperatively, mostly intraoperatively rather than postoperatively, they are likely to be either hypertensive or hypotensive if you are not careful. So how do you maintain hemodynamics? One combination that is advised is a low dose nitroglycerin with titrated phenylephrine. Low dose in the sense something like 25 micrograms per minute, 10 to 25 micrograms per minute. Either agent alone can worsen the hemodynamics. Phenylephrine is known to stiffen the vasculature, and it will cause prolongation of systole and reduce the time available for diastole. Whereas nitroglycerin alone will cause venodilation and can reduce cardiac output. Whereas when they are combined, low dose infusion of nitroglycerin with titrated phenylephrine. Titrated phenylephrine in the sense I am thinking of doses as low as 25 micrograms bolus. 25 micrograms bolus. So this will preserve vascular distensibility. It will avoid reduction in preload. It will maintain coronary perfusion pressure. It will maintain stroke volume with minimal cardiac work. On the face of it, combining these two drugs is counterintuitive, but this is an approach that often works well in multiple situations, not just, for example, this is with regard to diastolic dysfunction. In the case of treating RV dysfunction, a combination of milrinone with noradrenaline works quite well. So this combination of a dilator plus a constrictor is something that works well in practice. Now coming to not just regional, neuraxial block, regional is regional as in the sense regional nerve block will be very good in this patient. But when you have to use GA, you should have to, I mean, there is no other choice, you have to use GA, general anesthetic. But if you have the option of using a neuraxial blockade, epidural wins all the time because these patients are poorly tolerant to massive shifts in fluid. So epidural is nice because it will provide a gradual reduction in sympathetic tone and enable a smooth transition from the unblocked to the blocked stage, as in the sense blockade of neuraxial. And in any case, an epidural opioid is always advisable as a means of postoperative pain relief. So how to manage hypertensive crisis? These are very likely to occur in the postoperative period. Again, sound anesthetic practices, a plan for postoperative analgesia, prevention of shivering. And what I want to mention is this drug, intravenous nicardipine, which is a short-acting calcium channel blocker. It acts within about half an hour and lasts for 2 to 3 hours. So this is the preferred drug because it maintains coronary perfusion as well as cerebral perfusion. But what we use is the combination of beta blocker with nitroglycerin. So in the postoperative period, if a patient is showing any of the following signs, consider it likely that the patient is already in or is about to develop diastolic heart failure. Systolic blood pressure more than 160, diastolic more than 100. The patient pre-op echo showed a concentric LVH, and if the patient is had tachycardia or required volume boluses, and all these can be improved by reducing heart rate and restoring sinus rhythm. So this is what we did in our index case. We restored sinus rhythm. So the patient was developing hemodynamic instability. BP was dropped, systolic BP dropped to 100. So the patient underwent synchronized cardioversion, and amiodarone was started. She was treated with diuretic, and nitroglycerin was started to control hypertension, and she was put on CPAP. And with all this, she improved over 12 to 18 hours. Now, if an inotrope is required during this phase of diastolic heart failure, there is usually no role for sympathomimetic amines. I'm thinking of something like adrenaline or dopamine, which can potentially cause a lot of increase in heart rate. It is poorly tolerated by this patient, but milrinone is a good drug. As you know, it's a phosphodiesterase 3 inhibitor. It has inotropic as well as vasodilatory action with minimal increase in heart rate. The advantage is that the lusitropic effect, the ability to improve diastolic function with milrinone is said to be more when there is cardiac failure. A bolus dose of 50 microgram per kg, this is over 60 minutes. This is very likely to cause hypotension. This is something we very seldom use, although advised in literature. This is to be used with caution, but an infusion of 0.5 to 0.75 microgram per kg per minute is well tolerated by the patient. And another inotrope which can be used in the setting with favorable effects on diastolic function is levosimendan. It sensitizes the contractile elements of the myocardium to calcium. It has a vasodilatory effect and improves both systolic and diastolic function. So in the post-operative period, do not forget to start the beta blockers and ACE inhibitors. These two drugs have a favorable effect on diastolic dysfunction. And principles of management: prevention, treatment of atrial fibrillation in tachycardia. Atrial fibrillation is dangerous in these patients and needs to be cardioverted as quickly as possible, especially if hemodynamically unstable. And assessment of volume status is a clinical art. It should not, the patients need to be volumic, nor neither hypo or hypervolemic. And prevention of myocardial ischemia. And later on, the patient should be considered for cardiac resynchronization therapy, and that's up to the patient's cardiologist. Now, this is a flow chart showing how a patient with left ventricular diastolic dysfunction is to be treated with treated in the post-operative unit. Reduce afterload as possible. Two drugs to reduce afterload are inotropes themselves. Consider either milrinone or levosimendan. Dobutamine is also a choice, but much lesser of a choice compared to milrinone. Avoid arrhythmias and sustained tachycardia. Use beta blockers. Use dexmedetomidine, and treat atrial fibrillation. Balance myocardial oxygen demand and supply, particularly tachycardia, which can increase both demand and reduce supply. And the fluid boluses should be administered cautiously, and use inotropes without negative lusitropism. Negative lusitropism means drugs which unfavorably affect diastolic function. Mostly, we are thinking of adrenaline. And all of these factors can worsen diastolic dysfunction, either hypo or hypovolemia. Myocardial ischemia comes first, hypo or hypervolemia, tachycardia, and rhythms other than sinus. These patients are very much dependent on their atrial fix for complete LV filling. So sinus rhythm should be restored. Shivering, anemia, and hypoxia are poorly tolerated in the postoperative period. And pain is usually a reason for hypertensive crisis, and should be appropriately addressed in a preemptive manner. Thank you.
Thank you so much, sir. Yeah, thank you so much, sir. That was an excellent presentation on diastolic dysfunction. I see there are certain questions in the chat box. We can take up those questions. Dr. Advaita wants to know whether the anesthetic management varies according to the different grades of diastolic dysfunction.
No, the principles of diastolic management of patients with diastolic dysfunction is the same, except perhaps when the patient has restrictive physiology. Especially if the patient has irreversible restrictive physiology, the patients need to be counseled appropriately. And the surgery, if it is emergent, of course, it should be done. But time should be spent to optimize this patient and make sure this if this is reversible stage 3 function, the condition should be treated appropriately with beta blockers and ACE inhibitors. And a successfully treated stage 3 will have the appearance of either stage 2 or stage 1. So if that is the case, this patient needs to be taken up with the risk explained to the patient that in the postoperative period, the patient is very likely to have features of cardiac failure, which may need to be treated with non-invasive ventilation and additional drug therapy. But irreversible restrictive physiology is a dangerous situation, and surgery should be avoided if possible.
So I hope, Dr. Advaita, I would encourage the speakers to unmute themselves, and if there are queries, they can ask themselves also. In the meantime, Dr. Veena wants to know what is the dose of Nicardia which is used, sir.
Sorry, I got muted. So Nicardia is nifedipine, isn't right?
Sir? Hello?
Nicardia means nifedipine.
Nicardipine.
See, nicardipine intravenous is, I don't know whether it is available in all centers, but it's a good drug. Nicardipine process, it's a short-acting calcium channel blocker, dihydropyridine derivative. Its dose is independent of weight. You start with 5 milligram per hour, and we titrate upwards between 30 to 35 milligram per hour. And the advantage is that it will preserve coronary blood flow as well as cerebral blood flow. But if the question is with regards to nifedipine, that's a very dangerous drug. It should not be used, especially the habit of puncturing the capsule and administering it sublingually is not to be encouraged at all. Not a good practice at all.
Right, sir. So the next question is regarding fluids. What should be the fluid management strategy in patients with diastolic dysfunction? This is a pertinent question with regard to diastolic dysfunction, sir.
So answer here is that these patients are sensitive to volume status. Now, monitoring volume status is not an easy task, both intraoperatively as well as post-operatively. So this is mostly a clinical judgment. Now, if the patients have evident reasons for hypovolemia, like they are losing blood, that needs to be replaced either with crystalloids immediately and later on with blood. If large volumes of crystalloids have been used to resuscitate a patient intraoperatively, like for example, patient with a hypertrophied LV who's undergone general anesthetic and needed, like I said earlier, crystalloid resuscitation. The problem occurs when the patient is taken off from mechanical ventilation to spontaneous ventilation. So when the positive intrathoracic pressure from mechanical ventilation is changed over to the negative intrathoracic pressure for spontaneous ventilation, all the blood volume returns to the central pool and the patient is volume overloaded. So this is a critical point in the patient's post-operative phase. So this is the phase that you should be careful about. So if you have used crystalloids to resuscitate the patient intraoperatively, diurese them prior to extubation or immediately after extubation. So if these patients have, so these are patients who have undergone major surgery, so you should have an arterial line and Foley's catheter to monitor their urine output. Arterial line to maintain their blood pressures within the appropriate range. Other than that, for minor surgery or the considerations are not that important. If we can generally use a limited amount of fluid appropriate to the maintenance dose of the patient for intravenous fluid for the period for which the patient is nil per horum, that is fine. Problem comes when patients get a lot of crystalloid.
So what are the good measures of assessment of the fluid status? Do you think the intra-IVC diameter would be a good option in these patients?
Sorry, come again.
Do you think for assessment of the volume status, the intravascular volume status, for hydration status, do you think inferior vena cava diameter could be a consideration? Could we monitor that?
Yeah. So there are multiple measures for assessing the volume status. You can, like you said, the IVC diameter. All of them have their limitations. Pulse volume variation, the end-diastolic area, comparison of end-systolic area, end-diastolic area of the LV in the short axis view. Multiple measures are there. So these are relevant only when you need to resuscitate them, when you have to decide whether to resuscitate them using volume. So all these help in assessing the volume status. That's true, but I'm usually most worried about hypervolemia. You can have signs of that, like when their volume overloaded, like conjunctival edema, tissue edema, so on.
So Dr.
Basic
Veena,
rep.
yeah, Dr. Veena wants to know whether we should give the, I believe this is the maintenance fluid based on the holiday cigar formula, or should we restrict the fluids? The 4-to-1 rule.
Yeah, you can use the maintenance dose, but you need not replace the amount that was that there are different methods in which this holiday cigar rule is applied. The period for starvation need not be given to this patient. So if you during induction, you like I described, you induce the patient carefully by titrating the drug and start with the maintenance fluid for this patient for appropriate to the body weight, and then you focus on maintaining the blood pressure within the target range, and you need not worry about administering volume in a fixed range for these patients.
Dr.
2
Veena,
ml per kg per hour. Yeah.
Right, sir. So Dr. Veena also wants to know whether you can repeat the dose, when you could repeat the role of milrinone, sir. We mentioned milrinone here.
Yeah, milrinone is a ionodilator. It improves the contractility of the heart and reduces the afterload also. So it is very, and it is said that the lusitropic effect, the beneficial effect on diastolic function is better seen in cardiac failure. So these are the advantages of using milrinone. And besides, when you use it, in this group of patients, when they are in diastolic heart failure, their blood pressure often tends to be high. So a little vasodilatory, an inotrope with a little vasodilatory effect will nicely work in this situation. So that's it regarding milrinone.
And Dr. Sneha wants to know if there any other drug be used in place of nicardipine.
Nicardipine, yeah. The other drug what we use is nitroglycerin, because at low doses and titrated upwards. The two drugs available with us for intravenous use that will reduce blood pressure is nitroglycerin and sodium nitroprusside. Sodium nitroprusside we don't use at all, and not useful in this situation at all, because it produces profound reduction in blood pressure, as well as it causes tachycardia. Those are two very bad things to do at this time. Better will be nitroglycerin titrated upwards. 25 microgram per minute will be a reasonable starting dose, or 0.2 to 0.3 microgram per kg per minute, and titrated upwards.
Right, sir. And so I would encourage the listeners to unmute themselves, and if there are any other queries, they can ask sir directly if possible. Otherwise, I do not see any other question on the chat box, sir. So I think this is a very important topic of diastolic dysfunction, especially because we have seen that many post-COVID patients, sir, after they come for surgery after COVID, they are having diastolic dysfunction, and they are presenting for various surgeries these days. So do you get to see such patients there too, sir? Post-COVID patients with diastolic dysfunction?
No. My practice is entirely confined to patients coming for cardiac surgery. So we don't. We have had many patients who have come for cardiac surgery after they have had COVID, but we haven't noted. What is the stage of diastolic dysfunction you find in these patients?
So early stages only, stage 1, stage 2, not the restrictive pattern as much, but they are having diastolic dysfunction. There is one question by Dr. Mary. And this is a question whether spinal anesthesia or the central neuraxial anesthesia, whether it is contraindicated in diastolic dysfunction. I mean, there is a controversy. Maybe is it contraindicated, sir?
Contraindicated in the sense only because it can cause rapid say a vasodilation, and it will cause rapid deterioration of blood pressure. It affects myocardial oxygen supply demand. So that's why I said it is less preferable. I don't think you can get a handle on the rate at which blood pressure falls, or if the spinal becomes a little higher than that you desire.
Yeah, so probably in the early stages, we can consider probably, if at all it is to be considered as a contraindication, maybe in the restrictive pattern. But stage 1, 2 should not be, we have to be concerned, I believe. Is that correct, sir?
Yeah, stage 1 of diastolic dysfunction, every patient beyond the age of, let us say, 60, we can expect a grade 1 diastolic dysfunction, which is a very much age-related illness, because the myocardium the heart loses its myocytes due to apoptosis and cell necrosis, and it's a normal pattern to develop a grade 1 diastolic dysfunction with age. So spinal is not contraindicated in grade 1 diastolic dysfunction. Definitely not. Only thing I wish to stress is that if you know that the patient has diastolic dysfunction, be more vigilant in maintaining their blood pressure.
Another question by Dr. Saji, sir. He wants to know the vasodil and vasoconstrictor combination. What is this vasodilatory and vasoconstrictor combination, sir?
Yeah, this is a counterintuitive approach. The thing is, the diastolic dysfunction is, as I said earlier, an age-related dysfunction. The myocardium is becoming stiffer due to loss of myocytes, and myocytes are replaced by fibroblasts, which produce collagen. So the heart is now stiff. So this systolic period is prolonged, and the similar changes are occurring in the vasculature. The vessels are stiff. So when the heart contracts, it pumps all the blood into the aorta and major blood vessels, which absorb this energy and retains it within the wall. So what happens during diastole is this absorbed energy is released and the diastole is augmented. So what happens with aging is not just stiff ventricle, this is also stiff vasculature. So we need to preserve the vascular distensibility so that this hypertensive crises are avoided. So that's why we use nitroglycerin. Nitroglycerin is a gentle venodilator, and it can prevent the hypertensive. I mean, it started with the intention of preventing a hypertensive crisis. So, this low dose of nitroglycerin will also avoid precipitous reduction in afterload. And should your the combination, I mean, you at this point in during the conduct of the anesthetic, you would be using volatile agents, and along with this, at the start of the surgery, you might have started with nitroglycerin. Should you find that the blood pressure is dropping, a titrated dose of phenylephrine will just adequate to maintain coronary perfusion pressure and to maintain the diastolic blood pressure. This combination, it works, though it can sound counterintuitive.
Sir, one more question is, during induction of patients with diastolic dysfunction, which would be better, propofol or etomidate, and why?
Etomidate offers the advantage of being a very cardiostable drug, but propofol is not contraindicated. More than the drug, what is most important is how it is used. Like I said during the presentation, in the elderly, all drug requirements are reduced between 30 to 50%. They have a slow circulation time, so rapid administration of drugs is harmful. So propofol is not contraindicated. Of course, etomidate is beneficial. So that's my answer.
Yeah, I think propofol should not be contraindicated, but yes, etomidate would serve the purpose. So I thank you, sir. That was a very nice lecture. It was a very nice combination of the animation and the real life echocardiogram photographs. I mean, the physiology was very nicely presented. I'm sure the postgraduates will benefit from this talk. Naveen, sir.
Thank you, Dr. Sunil, for an excellent talk. And I'm sure with the presentation and the discussion subsequent to the class, residents and the delegates must have been benefited for this particular very important clinical aspect of a very nice lecture taken by you. And for the benefit of the delegates, the recording of this is available on ISA National YouTube channel, ISA NHQ, subsequently on ISA website also, isaweb.in, in the ISA Academics tab under the webinars. Next Monday, we will be meeting again for a class on anesthetic considerations in a patient of pheochromocytoma by Dr. Meenu Chadda from Indore. I once again thank Dr. Sunil PR for an excellent talk and sparing his time for the postgraduates and delegates. It's a pleasure having you with us. Thank you all. See you next Monday. Thank you.